First of all, I would like to thank the ECD Global Alliance for welcoming me at this ECD Medical Symposium. I'm a resident and I work in Pitié-Salpêtrière Hospital in Paris with Fleur Cohen-Aubin and Julien Arroche. And I'm glad to present you the result of our work on autoimmunity in a group histiocytosis. I'm sorry for my English. So, Erdheim-Chester disease is a rare non-ground cell histiocytosis, which is characterized by infiltration of various tissue by CD68 positive and CD1A negative histiocytes. Longer-round cell histiocytosis in Roeser group histiocytosis, which typical lesions are inflammatory, with abundant CD1A positive histiocytes. And ECD and LCA may be associated in so-called mixed histiocytosis. Histiocytes encompass monocytes, macrophages, and dendritic cells, which play an important role in inflammation. And macrophages and dendritic cells are crucial for the regulation of the immune system. Autoimmunity is present in a broad spectrum of diseases in which histiocytes are altered. For example, in Gaucher disease, antinuclear antibodies are found in up to 25% of cases, and in Roeser disease, autoimmunity has been described in up to 20% of cases. So autoimmunity has not been evaluated in a group histiocytosis, but a few cases of LCA or ECD associated with autoimmune disease have been previously reported. BRAF and MEK inhibitor are now widely used in group histiocytosis, and recently a case of polymyalgia rheumatic, an immune disease, has been successfully treated with probimetinib, a MEK inhibitor. So we screened all patients with group histiocytosis seen in the French National Reference Center of Histiocytosis of the Pitié-Salpêtrière Hospital. They were included if they had a group histiocytosis supported by histology and the presence of at least one determination of antinuclear antibodies. Patients were treated according to usual care, and targeted therapy were prescribed according to physician decision, usually when the severity of the disease required it. So we screened 276 patients, 187 with ECD, 51 with LCH, and 38 with mixed histiocytosis. 45 were excluded because of insufficient data in medical chart or no autoimmune biology. So finally, 231 patients were included in the analysis. The global prevalence of autoimmunity was 31% in ECD, 45% in mixed histiocytosis, and only 20% in longer-round cell histiocytosis. The prevalence of clinical or biological autoimmunity was so significantly higher in ECD than in pure LCH, and the prevalence of autoimmune diseases, that means clinical manifestation of autoimmunity, was also higher in ECD, although these difference did not reach statistical significance. Then we focused on the 196 patients with a diagnosis of Erdheim-Chester disease, pure or associated with longer cell in so-called mixed histiocytosis. Among these patients, the clinical characteristic, BRAF status, and treatment did not differ between patients with and without autoimmunity, and survival wasn't statistically different. 23 patients had autoimmune disease associated with ECD. There were 14 male and 9 female, with a median age at ECD diagnosis of 57 years, ranging from 26 to 86. The autoimmune diseases were 8 autoimmune thyroiditis, 3 primary Sjogren's syndrome, and 3 systemic lupus. There were also 2 BMR diseases, and 2 polymyalgia rheumatic, and 2 type 1 diabetes. We also noticed 1 antiphospholipid syndrome, a celiac disease, an autoimmune hemolytic anemia, a case of immune thrombopenic purpura, and 1 autoimmune alveolitis. Autoimmune disease was present before the diagnosis of ECD in 12 cases, and among them, the median time between autoimmune disease and ECD diagnosis was 84 months. 145 patients with ECD, that means 74% were treated with interferon alpha, and 19, that means 10%, received infliximab. Among those who received interferon, 43% had autoimmunity, and among those who did not, 37% had autoimmunity, which was not statistically different. In the same way, the number of patients with autoimmunity among those who received infliximab and among those who did not was 42% in both groups. 70. So, among ECD patients, 75 were treated with targeted therapy, that means BRAF or MEK inhibitor. Among them, 6 patients, that means 8%, had autoimmune disease, and 18, that means 24%, had positive antinuclear antibodies. 18 had persistent antiphospholipid antibodies, 2 with lupus anticoagulant, and 18 with anti-cardiolipin antibodies, 2 more with anti-beta-2 GP1 antibodies. We noticed that anti-cardiolipin antibodies titers significantly decreased under targeted therapy, and 1 patient with systemic lupus didn't have any flare during a 17-month follow-up under targeted therapy, whereas he experienced 1 flare during the previous 6 months without treatment. So, in this study, we showed that autoimmunity is frequent in ECD, but not in LCH. Autoimmunity and autoimmune disease were present in respectively 42 and 12% of ECD patients, but only in 20 and 3% of LCH patients. To explain this result, we have to remind that L group histiocytosis are myeloproliferative neoplasm caused by constitutive activation of the RAS/MEK pathway. This leads to qualitative and quantitative modification of dendritic cells, monocytes, and macrophages. It's possible that pathological histiocytes have altered function of immune homeostasis, proof modification of the phagocytosis or antigen presentation function. In LCH, pathological histiocytes acquire characteristics resembling to those of Langerhans cells, which are thought to have no role in systemic inflammation. And we found that autoimmunity prevalence was lower in pure LCH than in ECD. Another hypothesis is that the microenvironment of chemokines and cytokines around pathological histiocytes and the recruitment of immune cells participate to the induction of autoimmunity. An alteration of the destruction of circulating DNA by pathological histiocytes could lead to an increase in antinuclear antibody occurrence. And last hypothesis about Fas ligand and an apoptosis-inducing member of the TNF cytokine family, which is critical for the control of chronic immune responses and prevention of autoimmunity. Mice with T cells lacking membrane-bound Fas ligands have been reported to die from systemic lupus-like autoimmune disease and histiocytic sarcoma. And hereditary fast ligand deficits have been associated with Roeser disease. So we cannot exclude that an acquired or constitutional deficit of fast ligand explains the association of ECD and autoimmunity. To explain the effects of targeted therapy, we can recall that the RAS/RAF pathway is altered in almost all cases of ECD, and that ERK expression is increased in several immune diseases. In our study, we showed that anti-cardiolipin antibody titers significantly decreased under BRAF or MEK inhibitors. It was more difficult to draw conclusions concerning the evolution of autoimmune disease due to the heterogeneity of the diseases and the short duration of targeted treatment. This result may help to identify new therapeutic approaches in autoimmune diseases and to better understand the mechanism of the appearance and persistence of autoantibodies. So thank you for your attention, and I would like to thank all the patients who contributed to this work, the ECD Global Alliance for welcoming me, and one more time the Pitié-Salpêtrière medical team, especially Fleur Cohen-Aubin and Julia.
Question. How important are these autoimmune illnesses? It's not something I paid a lot of attention to. I know you probably haven't met most of these patients, but are they that symptomatic, or is this something that you find when you dig through the charts and you do? I know you do the serologies and all that.
I think the question come to us because of Roeser disease associated with autoimmunity, and we noticed that long-cell histiocytosis and Erdheim-Chester disease, it has not been described, but we had some patients that had autoimmune diseases in our service, and anti-nuclear antibodies are done for every patient as a screening. So
you were, I think, referring to the association between IgG4 disease and Roeser-Dorfman.
That's not on.
Okay. Did you have a look at the? Sorry if I missed it on the labs. Did you look at the distribution of antibodies? Do you see any IgG4 association with Erdheim-Chester?
sorry, I didn't understand.
There's an increase in IgG4 in some patients with Roeser-Dorfman. Do you also see that spilling into ECD as well? IgG4 elevation?
I think we didn't analyze it in the study, but we have the information and we could have a look on it later. But perhaps it's there is an increase, yes.
Ron?
Just a comment on Julio's question or comment earlier about autoimmunity and histiocytic neoplasm. So just in our own experience, the only in Roeser-Dorfman disease, that's when we see a patient coming in because of autoimmune hemolytic anemia or ITP, and that we have to manage the autoimmune disorder. But for Langerhans cell histiocytosis in the adult and also Erdheim-Chester disease, I can't think of any patient that I have to treat the autoimmune condition. The couple of times that we have seen rheumatologists referring patients to us are ECD patients who were misdiagnosed as aortitis, so inflammation of the aorta, and it turned out to be ECD involving the aorta.
Yeah, that's my experience too, or some other joint problem that they can't explain.